was supposed to be. So
Okay.
I did something that was about 20 minutes.
Okay, I think now we can start the session. So hi everybody, my name is Manasi Sharma, and I'm the lead of live sessions here at PHS. And today we're going to be hosting the session with Dr. Carey. And along with that, we have our outreach volunteer here with us. Her name's Jennifer.
Hello, how are you?
Okay, so we're just going to start off with a brief introduction, and then I'll pass it on to Dr. Carey. So once again, thank you everybody for joining today's session. And this is Pre-Health Shadowing, which is an international student-led nonprofit. So in this meeting, we're going to provide you with closed captions to accommodate students of all abilities and needs. And if you have any questions, feel free to email us at info@prehealthshadowing.com. Also save us as a contact so we don't end up in your spam. If you want to stay in the loop with pre-health shadowing, don't forget to sign up for our email list, and you can also follow us on social media, and here are our handles. So we host students from all over the world, and for example, me, I'm located in San Jose, California, and pre-health headquarters are also in California, and I'd love to know where you guys are following from, so feel free to add that in the chat. Ooh, New York, Niagara Falls, New York again, California, Michigan, Chicago, Philly. Thank you guys. This is a really diverse group. Also, if you're interested in being part of the pre-health shadowing team, you can register as a volunteer on our website on this page over here, and it's 100% remote, and you can do it from the comfort of your home. And additionally, if you'd like to join our leadership team, our applications are open, and this is also 100% remote. And here are some of the available roles we have. And in order to register for this, you got to use the following link, and you can sign up for an application and interview. The link is also in the chat. Apart from this, if you are a high school student, we have a high school training program which offers leadership and healthcare educations for pre-college learners. And for this too, you can fill out the interest form for the HTP program on our website. And once again, PHS runs on donations, the valuable donations from you guys. And even if you can donate like $1, it would be really, really helpful. So yes, donations are really encouraged. During the session, if you have any questions, feel free to type them in the chat, and you could also raise your hand, and our co-host will ask them during the Q&A. Make sure to take good notes during the session because our post-shadowing assessment will be available after this meeting on the PHS website. And over here, you can take a digital certificate which verifies your hours. And you could also put this on your LinkedIn or resume. And also, it would be really great if you guys could turn on your cameras because it helps us replicate an in-person environment and make it more engaging. Thank you. And now I'd like to pass it on to our host, Dr. Carey. If you would please like to introduce yourself and go ahead with the presentation.
Happy to. Can you guys hear me okay?
Yeah.
Excellent. All right. So it's my pleasure. My understanding, because pre-health shadowing didn't exist when I was where you guys are, but my understanding is that, I'm going to give a short talk about my own career and some of the challenges that, you might think about as you're developing into a health-related career. And then it's open for questions and things. Is that right? Terrific.
Yes,
Well,
that's
then
how
I
it
will
works.
get started, but I will say that feel free to, wave or whatever if you want me to stop on any of my any part of my presentation. It should take about, I don't know, 20 minutes or so. Okay. So you can see my slides, I assume.
Yes, they look fine.
Okay, good. Just gonna pull them out. Do you see one side or two?
Just one.
Okay, good. All right. So I'm Lisa Carey. I am an oncologist. I'm a breast cancer doctor, and I'm a what's called a clinical translational researcher, which means I design clinical trials, but I also do work with laboratory-based scientists to try and understand the biology that explains response to therapy. Um, and I am at UNC. So you'll see the UNC logos throughout here. And I'm going to talk a little bit about like how I got here, just because it's the way I know. And then you guys can ask me anything you want. I did serve as the division chief for many years for hematology and oncology, and the physician in chief of the cancer hospital. So I've had leadership roles across not just my own field, but other oncology based fields. And I serve as the deputy director for our cancer center. So my path, I went undergrad to Wellesley College, which is a women's college outside of Boston. From there, I went to Johns Hopkins in Baltimore for medical school, but I also did a graduate degree at the concurrent with my medical training in clinical investigation. So I had formal training in designing clinical trials, and I spent time in a lab so that I could develop um, the how to design trials that include the parts about biology. So that's me at UNC. I'm actually pregnant there with my youngest child, who's now an orthopedic or resident in orthopedics at WashU. But starting early with scientists, so I'm surrounded there by a scientist on the left, my boss, the cancer center director on the right, and the guy who's talking to me is a famous epidemiologist. And so that was what I was thrown into, like work with all these people and learn how to bring them all together. And this is at UNC Lineberger Comprehensive Cancer Center here in Chapel Hill, North Carolina, and the Baz Knight Cancer Hospital where I practice, which is basically across the street. So I was hired to build things. UNC at the time didn't have much of a clinical program. It didn't have much of a trials program, and it certainly didn't have a translational collaborative research program. And so, I've actually worked very hard at working with population scientists at our School of Public Health, trying to change and inform practice and to tailor treatment. But as I mentioned earlier, everything I've done is part of a team. Like none of it was me, thinking deep thoughts over in a corner by myself. And so I think that's actually, a key attribute is being able to do team science and to put maybe your own agenda to the side in order to get a shared agenda that benefits more broadly. On the right-hand side, you can see me with two of my kids, the two who ended up going into medicine. I have one black sheep who's in business. He's the oldest. My daughter on the right is the one who's an orthopedics resident right now at WashU. The one on the left is actually an MD PhD student entering his last year at UNC. So it worked. My kids have continued on the trail. So I'm a breast cancer doctor, and I'm going to talk a little bit about breast cancer as an illustration of why a career in these either health sciences or in medicine can be incredibly rewarding, and also a little bit of the trials and tribulations along the way. So it's not too long ago, I'm showing you here, before the 1970s, every patient was treated with one thing, surgery. And they had what's called a Halsted or radical mastectomy. The problem with the radical mastectomy, it was incredibly deforming because you take the breast as well as the underlying muscles, and you can see on the left-hand side that causes a sort of a flaying of the arm and a lot of deformity. It also causes lymphedema, which is that puffy arm compared to the arm that wasn't operated on the side that wasn't operated on. And the problem is that even though they would go through these incredibly deforming large surgeries with a lot of toxicity, there was 50 to 60% of the women who developed breast cancer died of it. So it was very common. It was clearly very lethal, and it was also very understudied. And so this is another picture I'm throwing in here. That's me with my mother and my grandmother. That grandmother, actually, both my grandmothers had breast cancer. One died of it, the other did not. And frankly, that grandmother didn't tell anybody she had it until just before she died, and she was completely untreated. And that was, you know, it was a lot of stigma, and that wasn't that uncommon back in the 60s when this picture was taken. So a lot changed. You know, in the 1980s, the National Cancer Institute, or NCI, began a series of trials, and the trials were, do we have to do all that surgery? What happens if you add radiation and do less surgery? And the beginning of medical therapy for breast cancer. In the 90s, research advocacy by patients and their loved ones became a huge part of this. They actually learned from the HIV/AIDS movement how to do this. You know, it was there were like playbooks on how to do advocacy and to get the federal government in particular to put money into research into particular diseases. Started with HIV/AIDS, which was not funded for a long time. Then it went to breast cancer, which at the time was very unfunded. They were quite successful, and they ended up with, in addition to normal funding, they got congressionally mandated funding from the Department of Defense, and a number of foundations were formed. And it's true that in 2024, more than 40% of annual US funding for breast cancer research actually doesn't even come from the federal government, from the NCI. And you can see that represented in the right, where breast is you know, it's very common. You can see it's one of the most common diseases, but it also has a high degree of funding, and I'll show you how that's helped. So I told you the first thing that happened was less surgery. And so you can see that Halsted procedure in the upper left-hand side starting in 1882, but it was still being done the same way in, you know, in basically 1982. And then, so I don't know if somebody's trying to talk. You can see in the series of things, there were, you know, the outcomes of less surgery. It was successful. Patients didn't have more relapses. If you did less surgery, they moved to a modified radical mastectomy where they don't take all those, all the chest wall muscles. And then they learned to do a lumpectomy with radiation, where patients can have a much smaller surgery and much less deforming. And so the truth is that these were, you know, very, very much less morbid, meaning less side effects, but it didn't change the fact that it was a common disease, and it didn't change the survival from it. It just meant that patients were tolerating the treatment better. And it wasn't until science and the explosion of scientific advances that we really started to see a change in survival from breast cancer. That included, you know, enough information to subset breast cancer instead of treating it all as one thing into 3 distinct subtypes that are defined by proteins that are found in or on the cancer that are themselves targets. And there was biomedical technologic advances that I'm not going to get into, but massive diagnostic and therapeutic evolution of our ability to understand the underlying biology and to develop drugs against it, and to prognosticate and identify which cancers don't really need a lot of therapy and which we need to be very aggressive for, and an explosion of targeted treatments. So how about now? So breast cancer is still really common, but it's a lot less lethal. I mean, the truth is, it's just as common. We haven't done anything to learn prevention. There are a couple of strategies for prevention, but they're not used very much because they aren't that effective. So you can see the incidence, meaning, you know, how often do people get the disease, is very high. There's a lifetime risk for a woman in the United States of 13% of getting breast cancer. In 2024, that was just over 313,000 cases per year. But you can see the mortality has plummeted. That's the pink line on the bottom. And you can see it going down, starting at around, you know, 1990-ish, which is when all of these biologic advances became more translatable into the clinic. And you can see what a huge impact that has had. And it's a 43% decrease in mortality just over the last few years, which is quite remarkable. And just to be clear, 75% of that mortality decrease is from better treatment. It's screening has had an impact, but it's about a quarter of it is from picking it up early. The rest, really the vast majority, is from the treatments that we offer. But that means that, as you're unraveling the biology and developing targeted therapies, that means that our drugs are incredibly complex. They're much more effective, but they're very much, we used to just give chemo to everybody, which is sort of dumb drugs. Now everything is smart drugs, which means you have to be very careful about identifying the appropriate patients and the appropriate tumors for that treatment. And so this is true if you see in the pink, cytotoxic means chemo, endocrine means, hormonally directed therapies, which are quite important. Targeted means there's something about the cancer, a biology of the cancer you can identify, and you're going to develop a drug that targets specifically that Achilles heel of the cancer. And you can see that there's a massive shift in drug development into targeted therapies in breast cancer and frankly, every other cancer too. So what does that mean? We have a lot of survivors of breast cancer, right? So many patients are cured, many more patients are cured. And you can see that on the left-hand side. You can see this is true of all that diagram is cancers in general, because a similar story can be said about colon cancer, lung cancer, prostate cancer, et cetera. We've done much better with some cancers than others. We haven't really budged the needle on pancreatic cancer, for example, or glioblastoma, which are brain tumors. But certainly many cancers, and breast cancer is one of the particular ones, have done so much better. And if you get to like pediatric cancers, like pediatric leukemia, which was universally lethal, 100 years ago, is now almost always cured. But it's also very expensive. So we have 4 million breast cancer survivors in the US. Some of them have cancer active, but it's being controlled. But the cost is really remarkable because it's so common and because we've been so successful at treating it. The cost is $30 billion per year in the US. So I'm going to talk a little bit about a couple of things that I've been particularly involved with because they're illustrative of that team science I mentioned earlier and the importance of finding people that you can help them, you can contribute, and they can help you. So together with Bob Milliken, who was the epidemiologist who then he passed away, and that this particular study was taken over by Melissa Troster, another epidemiologist, is a thing called the Carolina Breast Cancer Study, or CBCS, which you can see it outlined in pink in the middle. It's a population-based study, meaning it represents the population of North Carolina. It's not my patients who are selected by, they're being able to get to Chapel Hill or whatever. It is a population-based study. It's representative, but they tweaked it. So it's representative, but they wanted to make sure it was representative with a focus on women. 50% had to be Black women with new breast cancers, and 50% had to be women under the age of 50. And they've done that for now since 1993. The reason they did that is because those two groups tend to be underrepresented in regular epidemiology studies if you just take everybody. So they had to adjust it so that you could actually say something about women of color and young women with breast cancer. And couple of observations have come out of this, and you can see the JAMA paper on the right-hand side. That was the first paper that I was the lead author on, and it was the first time we looked at molecular subtypes of breast cancer, race. We also looked at age, but that didn't make it into the title, and survival in the CBCS. And that we published in 2006, but we've updated it with more sophisticated technology, and a couple of things that we found out, and that is race and age differences in outcomes, survival. So I told you there was a 40% plus improvement in mortality from breast cancer in the US over the last 20 or so years, but some groups have benefited more than others. So older women have benefited more, white women have benefited more. There's clearly disparities in outcome in Black women versus white, and in young women versus older women. And in part, this is due to biologic differences in the kind of cancers they get. Now, of course, you want to say to yourself, why would they have a biologic difference? What are the reasons for that? And that's a whole different talk. And there's some some hints. We don't really know, but there's some hints as to why, if you get a cancer, it looks a little different. And you can see here in the red are those basal-likes, which are the worst prognosis kind. And you can see a very big difference in a younger woman, an older woman, and a Black woman and a white woman in whether the likelihood that the cancer they get is going to be this basal-like kind. The best prognosis one is the dark blue. And of course, you see the reverse, which is you're much more likely to have this best prognosis one if you're an older woman or a white woman. But then it gets more complicated because the largest disparities by race in survival were actually in the dark blue one. So yes, you could have some differences in the kind of cancer you got, but if you just looked inside of the good prognosis dark blue ones, actually the biggest black-white differences that we saw were in there. So if you got the red kind, it was a bad prognosis no matter what. If you got the blue kind, it was really good, but only if you were a white woman. It was not as good if you were a Black woman. And you know, the survival was just really different. And there's a reason for that. And it has to do more with access to care. So the other thing is true is when we talk about trying to tailor therapy and to be smarter about how we treat cancer patients, it isn't just about trying to tailor therapy for medical reasons. There's a lot of different reasons that patients suffer with their cancer and with the effects of having a cancer diagnosis. So this is also from the CBCS, and it shows you that within 2 years of diagnosis, everybody has a consequence, right? A high proportion of patients can have consequences from a financial standpoint of a cancer diagnosis. This is true of many diseases, but cancer is particularly stunning in this regard. And you can see any negative financial impact, 40% of white women, 59% of Black women report anything. And you can see the kinds of impact on the right-hand side. So this is from colleagues of mine, Stephanie Wheeler and Katie Reeder-Hayes, and they analyzed this within the Carolina Breast Cancer Study because there was so much data that could be collected, and they were able to show a very high proportion of patients that had this kind of problem, and B, that there was a racial difference in that regard, just as there is a racial difference in all the other things we measured. So let me talk a little bit about drugs and trials. So, you know, the way we test drugs and we test new approaches is to do clinical trials. That's what I do. I'm a clinical trialist. I design trials. I say, okay, here's the problem. Let me design a trial that will answer that question and we'll know what we should do. So if you want to design a trial that is patient-facing, and say the original trials, like do you need to do a very deforming surgical procedure or can you do less surgery? That's the kind of thing that you have to get a sponsor for. And it's hard to get a sponsor for a trial like that. The most of the trials in the United States and increasingly around the world are actually done by commercial entities. They're pharmaceutical companies, they're device manufacturers. That's good, right? They're the ones developing the drugs, developing the assays, developing the devices that we use, and that's been a real improvement. But the fact that there's 10 to 1 of those kind of enrollments versus enrollments in federally sponsored trials that are more practical, is a problem, because a pharmaceutical company is trying to get their drug out there and they're more likely to add to the therapy than say, maybe we don't need to give so much therapy, let's do less. And when we did a survey I run a cooperative group breast committee, of the 5 highest priority unmet clinical needs that from a survey from a little over a year ago, 4 out of 5 of them would need large, expensive trials to answer the question, and were also of a type that would be unlikely to be appealing to any industry partner. So that's a problem. So I'm showing you here, this is actually, you know, if you want to do clinically meaningful questions, one of the ways to do that is to be involved in national entities. So I have the pleasure, that's me and my co-chair. We run one of the cooperative group breast committees. You know, it has a ton of doctors. It's, you know, surgeons, radiation docs, medical docs, scientists, et cetera. We do a lot of therapy, and that's where the survey came from. So I would say among the things that are opportunities is also think broadly, because there are people like you around the country. They may not be at your institution, but find the people who are like you and put yourself out there. When we did the survey, this is the big trials with practice implications. We did a bunch of trials on the basis of that survey, and you can see the answers that we got were very clear answers, and they were all published. And these are all, essentially practice changing things that came out of questions that we wanted to answer and that we could do with federal funding. Some of these also involved industry funding, and you have to be clever about that. So, for example, the third one down, that's the New England Journal, it actually just was published today. That one involved the pharmaceutical company actually paid for most of that, but they were letting us ask a practical question and let us own the way we asked the question. So let me talk about biomarkers and the science part. I had the pleasure of designing a trial. You don't need to know the details of the trial, but you can see a schema, which is kind of how we design, the short form of how you describe a trial. And it was basically an NCI-sponsored trial saying if you add 2 drugs to chemotherapy, is it better than just adding 1 drug? It was my trial. I designed it and I got to run it. This is quite a few years ago. And I put here Carey trial principles, which was that I insisted on a bunch of biopsies because I said, if we're going to answer the clinical question of adding drugs, I also want to answer the biologic question of why did some patients do better than others, and see if we can figure out how the biology contributes to that. That was through philanthropy. So I mentioned support for the kind of work that I do comes from the NIH and the NCI as a component of that, from sponsors that you negotiate with and want to help, and also from philanthropy. And I have a lot of philanthropically supported research. And this is one of my chief scientific collaborators on the right-hand side. We've been working together for 20 years. He's actually kind of a famous scientist now. And I just want to point out, it's not important to know the drugs, but just remember a traditional clinical trial is 2 versus 1 drug, or a better versus a worse drug. And those were both important, but was even more important was the biology of the cancer, because it turns out that breast cancer and a lot of diseases are more heterogeneous than just you think they are when you first look at it. That actually mattered more than any of the drugs that I was giving. And whether the immune system was actually turned on or not was just as important as the drug choices. So the drugs matter, but not as much as cancer biology and patient features. And, based on that, I worked with a number of other people, brought in a bunch of collaborators who couldn't do each. We could each do it alone, but it's better to do it together. And we ended up with about 1,100 tumors from a whole bunch of trials. And that's turned into an assay that is now commercially available in Europe and being tested in the US. Also to help you
have like
tailor
everything
therapy.
organized. No, really?
So I just want to say this is 2 slides that took me 10 years of work. And during that time, there were 10 FDA approved drugs that did not have biomarkers that go along with them. So it's a bit of an uphill climb. And then finally, my role in clinical care. I'm a breast cancer specialist. You don't want to be taking care of your colon cancer. I'm not that good at it anymore. But I do think that to do good research, it's good to be attached to the clinic and to the patients. And I spend a lot of time with patient advocates who tell me what they think is important to them. And that helps me design the trials and decide what to prioritize. And you're trying to do a lot, but it's really worthwhile. And I think it's mission driven. So it's not, people say, oh, it must be exhausting, but it isn't, because it's so worthwhile. And I'm a teacher. But I do a different kind of teaching at this point in my life. I teach oncologists. So you can see the oncologists on the left-hand side. And on the right-hand side, I'm very involved in practice guidelines. And, they get a bunch of us together and we vote on things for international treatment guidelines. And then my last thing, you always keep reinventing yourself. So I am now the head of a thing called UNC Clinical Research Partners, which is a joint venture between our university and our healthcare system to develop clinical trials that could be accessed across our healthcare system. We have a lot of trouble getting trials to be available to patients being seen in more rural counties of North Carolina. It's easy if they're near the academic medical center. It's hard if they're out, far away from anything. And so we're trying to create a system that will let it be more available. So wish me luck. It just started. So this is if you're thinking of being a career as a clinical researcher in whatever field, it helps to have training. So I had training in trial design statistics. That's what I got that concurrent with my clinical training. I got a master's in clinical investigations. It's good to have a clinical role. You have to have some protected time so you can actually take what questions you're seeing in the clinic and develop research around it. It's crucial to have talented partners who want to work with you, and you have to be willing to work with them and spend time then in ways that isn't necessarily just for you, but is to help somebody else. Finding an institution that values you and invest in you. And you also have to realize that if you do this kind of work, you are not always going to be the smartest person in the room. In fact, most of the time you're not. There's a whole bunch of smarter people, and that's okay. And I think that was the end of my presentation. Thank you. So happy to answer any questions. I like
Thank
all
you
the
so
clapping
much for
hands.
your
It's very
lovely
sweet.
presentation. And I loved hearing about your work. I have one question for you, and then we can progress on other people with their questions.
Sure.
The question I had for you was what inspired you to specialize specifically in breast cancer rather than like other cancer types?
Well, breast cancer. So let me go back a bit and say, why did I go into cancer as opposed to be a cardiologist or whatever? So I started out as wanting to do research. I did research when I was an undergrad. And I thought I would be I didn't know if I want to do MD or PhD. And it was really the desire to see patients that made me do an MD as opposed to a PhD. Then when I got to medical school, I did a different kind of research. I was in a surgical field, and that was fun. But it didn't interest me. I didn't like the procedural aspects. You have to like to be, you have to like to operate. It turns out to be a surgeon. Who knew? So I wasn't that thrilled with being in the operating room. So I decided to go into medicine. When I was in medicine, I loved the science of oncology because there was so much that was going from the lab, discovery into the clinic. It was like so fast, and I wanted to be part of that. But I was scared of going into oncology because I thought it would be depressing. But then I spent a Christmas of my junior year as a resident assigned to the cancer ward over Christmas. So like it's a whole week. The way it worked in the olden days, back in the olden days, was you had a week on. You're essentially on. You were there all the time, and then you had a week off. And so I was assigned the week on, which was the Christmas week, and I had the New Year's week off. And so I'm like, well, this is going to be depressing. I'm going to be in the cancer hospital for the whole week around Christmas. And it's going to be very depressing because many of these patients this will be their last Christmas. And it was not depressing at all. I mean, the patients were remarkable, and they, the joie de vivre was incredible. The nurses and they were they were having a, like, not the ones that were super sick, but like to the extent that they could, the human spirit, bubbled up, and they were very inspirational. And so I said, okay, these are the people I want to hang out with. This is like, I would love to take care of these people. So I went into oncology. And then when I was in oncology, the breast cancer field was so collaborative. People weren't competing to do stuff. They were working together. It was just very obvious to me, at least, at my institution, right, where you're training, you see what you see. And I thought, well, that seems really appealing to me. So it was a combination of those things.
Yes, that was a really great answer. Thank you so much. Now I'd like to pass it on to Sarah to ask the questions for Q&A. Is Sarah here?
Yeah, sorry.
Mhm.
Emily S. wanted to ask what the leading causes of breast cancer were, and if there were any cases before the 80s that were noted.
Oh, breast cancer has been around forever, right? I mean, there's sculptures from, Egypt and Greece and whatnot with clearly breast cancer. So, breast cancer has been around forever. We don't have a great handle on the causes of it, other than there's a subset of people who have inherited kinds, and you can measure that by some inherited susceptibility genes. The most famous ones are called BRCA1 and BRCA2. It is true that incidence is higher in Western countries. Probably diet plays a role in that. Certainly longevity matters, right? If you're dying of, infectious diseases and the average survival is 36 years, you're not going to have time to get cancer. It's a disease of an older population. Most of my patients, so 2/3 of breast cancers, are older than age 50. So it's clearly if you don't die of communicable diseases, you're more likely to get non-communicable diseases like cancers. There's other stuff that clearly is playing a role, but that we haven't quite sorted out. Obesity is a risk factor for breast cancer. There's some variable risk factors. Breastfeeding, if you take all breast cancers, is actually protective. Things like that. But we don't have a great handle on it, and it's probably very multifactorial. But breast cancer has been around forever, and we just didn't have very good tools to treat it, and that's why most people died of it relatively quickly before the 80s and 90s.
Right. Kelsey wanted to know, what does the hardest part of or hardest day at your job involve, and how does you and your team take time to kind of reflect or process difficult cases?
I'll take the second part first. So difficult cases, we meet together. So there's 7 of us at UNC that are medical oncologists like me. There's another 4 surgeons and 5 radiation docs. And we talk together every week. And frankly, we send texts or emails to each other a lot when we want to go over cases. And then I have the pleasure, I actually work with a lot of people around the country. And so, we have there's a group that, what would you do? There's a what would you do email string that is commonly used. It's every week there's 1 or 2 from person at San Francisco, the person at Memorial Sloan Kettering, the person at Dana-Farber, the whatever. We all know each other very well because it's a small community that does the kind of work that we do. And we say, what would you do? Here's my case. And then we argue, frankly. No, generally we come up with, there's a little bit of debate. Generally that it's very uncommon that everybody says the same thing, but it's common that the general themes are the same. Your first question, what's a hard day? I'm a medical oncologist, right? I take care of, I told you the evolution of my job and the experience of my patients over time. But the fact is, I still, like 20% of my patients die. And, on average, they don't die, 40 years later, they die within 10 years of their diagnosis. If they're going to die, they either don't die at all, right? They don't die, or they tend to, on average, if they're going to relapse and die, they do it within the 10 years or so. And, I'm the person who manages that trajectory, including conversations about prognosis and goals of therapy and hospice. And, I'm their doctor through that whole span and that whole journey. And, it's incredibly valuable and it's incredibly fulfilling to be able to help people. And, I think I help people with really hard conversations better than most people do. There's a little psychiatry involved in the kind of work that I do. But you can't make it not hard, right? These are people that and these are people, what you can't do is have it be about you, right? It's not you, but it is still hard. But your job is to make it as easy for them as it can be. But that's a hard day when you're certainly having any of those conversations and having to have multiple of them. That's a tough day.
Definitely, I get that. Would you say, were there any cases in your career that shaped the way that you treat or support your patients? Or maybe looking back, is there a story that continues to motivate you or your work in breast cancer?
Sure. Well, again, I'll take the second one first. I learn from my patients' experiences all the time, and it affects, the things that I do. I was a early adopter of a certain approach to managing infection risk with some of the drugs that we give to metastatic breast cancers, because I had a patient who died, and she died of an infection that came because of the impact on her immune system of the drugs I was giving her. And, so I started changing the way I managed those drugs. It turns out that I wasn't alone in that. And then they changed the recommended algorithm for how you treat patients when they're receiving those drugs. But, I changed early because I had that experience with that patient. And I'd had others that had struggled, but never that bad of an experience. But after that, I said, I don't want this to ever happen again. So, that's an example. And that's just that's one example. And I only remember, I'm mentioning it because I literally was talking about it yesterday, because that's when they changed the algorithm in general. But I'm like, yeah, I'd already started doing that because I had really, this is, you learn from your own experience first. Are there patients who inform, like, who I think about? I've had some amazing patients over the years, and I think of them all the time. And sometimes, that, they taught me, how to, whatever you're facing, whatever I'm facing, whatever I have faced in my life is easier than what they have had to go through. It puts your own, listen, I've lost family members, and we've all had tragedy come into our lives, but it helps me be grounded because I am always with patients who, frankly, with amazing grace, go through something that I haven't had to do. And it keeps you, kind of reminded of that. And I also have, like, just last weekend, I happened to be in the mountains of North Carolina with friends, and, the person managing the restaurant that we happened to go to was the daughter of a favorite patient of mine, one of my first patients, who passed away. And her daughter at that time was quite young, and now is grown up, and I wanted to tell her how much I loved her mom, and she wanted to tell me how much she appreciated how long I had kept her mom alive, because she was alive for quite a few years into this child's late teenagerhood. So yeah, that's all the time, all the time.
Another question we got from Caitlin was, how does breast cancer treatment vary in different parts of the world, and how effective are they?
I'm
And
sorry, I would like to interrupt you. Sorry, Sarah.
no worries.
So Zan has raised her hand, so I think she has a question. Would you like to go ahead?
Yes, just a second. I am so sorry. So my question to you is, you said something about remission for at least 10 years. Is there some cases where it could go a little longer than 10 years, say 16? And then a person can go downhill from there?
Sure. Yeah. I mean, there's a lot of variability. So what I always say to patients, and that's specifically about metastatic cancer, once it's come back and it's in the sites where I can't cure it. But I've had patients who are, decades into that therapy, and the drugs we have happen to be very effective against their cancer, and they're still doing fine. And I've had others that die within a year. because none of the drugs that I have work. So yeah, there's a lot of variability there. That's why the interrogating the biology is so important to me.
So how much is that hereditary? I mean, like,
Probably not very much is hereditary. It's just the nature of the cancer. Probably most of it has to do with the biology of the cancer, and the biology of the cancer doesn't seem to differ that much between inherited and non-inherited breast cancers, with one exception. I have drugs that only work in inherited breast cancers. One class of drugs. I think what was the other question that I can't remember this
Yeah,
the question
Caitlin wanted to
there.
ask how different breast cancer treatments vary in different parts of the
Oh,
world and their
a lot.
effectiveness.
Well, if you can get the drugs, they tend to behave similarly around the world. The problem is you can't get the drugs because they're very expensive, or they need to be, they have to be given by an IV, and you got to have an infusion center, or they have to be stored in a certain way. But so access and cost is a real obstacle to effective therapy. Now there are what are called biosimilar drugs. So there's a drug that's made by a company, and after the patent life ends, you can have drugs that are made by companies that make generics. And so there's a fair amount of that. The World Health Organization actually has a list of what they consider to be essential oncology drugs. And so, that's out there in the world saying, listen, you have to have at least these drugs in order to take care of cancer patients. It's not breast cancer, it's all cancers. But it's a pretty stripped down one compared to what's available in developed countries. And it matters, right? That matters.
I'm sorry to interrupt. I had a quick question. Just going back to when you said that you use one specific drug if the cancer is hereditary, what is that drug? And also, are you able to use a different drug if the patient's cancer is hereditary? Is it just one specific way about treating the patient? Or maybe I'm understanding it incorrectly.
There are drugs. Yeah, no, I'm sorry. I made an illusion without actually framing it very well. So my apologies. In inherited breast cancer, those with inherited BRCA1 or BRCA2 mutations, there's a class of drugs that are very effective in them. They're called PARP inhibitors. And PARP inhibitors really only work in those inherited, and there's several PARP inhibitors that are available. They work generally fairly similarly. But they only work if you have either an inherited abnormality in BRCA1 or 2, or your cancer develops an abnormality in it, which also can happen. The cancer, you may not have inherited, but the cancer just, mutates those genes. And those, so those drugs were developed to take advantage of what BRCA1 and BRCA2 do. And when you lose them, how the systems the cancer relies on to live. So they're very explicitly, they work in inherited kinds. But I have a lot of drugs, and patients who have inherited kind or non-inherited, I still have the armamentarium of drugs that I can use. It's just that with inherited ones, I have one more class of drugs I can add to that, the PARP inhibitors. Does that make sense?
I see. Yeah, that makes a lot of sense. Thank you so much.
They're very targeted.
Yes. Thank you so much for answering.
Aisha, you can go ahead and ask your question.
I was wondering, for students interested in medicine, what is one piece of advice you have for us? And that could be whether it's related to like the job itself or related to the huge process of studying medicine.
I think if you want to go into medicine, the first piece of advice I give you is make sure you're doing it for the right reasons. You have to want to take care of patients. If you're not that sure about wanting to take care of patients, then there's a lot of other ways to get involved in the science and things like that. You know, I'd also say don't be scared of it, right? You know, it can be, it's a very rewarding thing. I raised 3 kids while my husband's also a physician, and you know, it worked out fine. It wasn't perfect, and there was a lot of chaos during their early years. But and you know, and I missed a lot of soccer games, you know, not all of them, but you know, there was always that trade-off because I had a sick patient or because I was on call or because of whatever. And all I would say about that is all my kids turned out great. And I think in part it wasn't, if I was not there because I was trying to make money, you know, like I was doing something that was just for something that wasn't meaningful, but they watched their father and me, and they knew why we were going into work on a Saturday morning. They knew why we weren't coming home till late. It was like the meaningfulness of what we were doing, like we shared that with them. We were always talking about it. And they all went into like valuable things, and they are very centered that way. So I think those would be the 2 kind of somewhat orthogonal pieces of advice. Don't be scared of it, but also make sure you actually want to do patient care.
Okay, thank you so much.
Because it is a long time. It takes a long time. It's an investment. I mean, I took, for my training, it was 4 years of college, 4 years of medical school, 8 years between my graduate degree and my training, my formal training, before I was like off being a faculty member. Because, you know, while you're in training, you're basically an apprentice.
I have a question.
Mhm.
So I am applying to PA school, and I am very interested in the research side of things. Do you know if there is options where I could work clinically seeing patients and then also be involved in research?
There are. It's a little bit more challenging coming from PA school or coming from a PA role, but it's not impossible, particularly if you're in a large academic center. You know, because PAs and nurse practitioners, so what we call APPs or advanced practice providers, you know, oftentimes have a very heavy clinical load. They have a lot of obligations in the clinic. So in you know, in my institution, it's, you know, 4 full days a week for oncology. And then the 5th day is writing, you know, getting chemo orders organized, following up on CAT scans and blah, blah, blah. You know, when I started, I was about 2 days a week in clinic because I was expected to have my research time. So there's a little bit of a different place where you're starting. But if you're at an academic center, then you can find someone doing research that has a clinical component where they're obtaining blood or they're doing questionnaires or they're doing and you can get involved, and you can help them by being in the clinic end of it. That's probably the most reasonable part of it. PAs and nurse practitioners also can oftentimes get involved in quality initiatives because they're so clinically involved and engaged. So things like where they're trying to do research on, you know, how is care delivered in your hospital, and there are quality initiatives. Oftentimes the hospital is actually sponsoring research to find out that if they're doing a good job on stuff. And that's another place where PAs and NPs can get involved. Also nurses.
Thank you.
That was a great question. Kirtika was wondering if we find that breast cancer is just as or more common because we have better methods of finding breast cancer, or is the data adjusted and we still find that it's due to other causational factors?
Yeah, you know, the methods haven't changed that much for detecting breast cancer. If you remember that slide that I showed where it's like the incidence slide, You can see a little uptick when mammography started to be done, but it's not very much. It's been a common disease for a very long time. It's less about the methods. Certainly, routine mammography, we start detecting a few more, but not in decades. It's been about the same. And frankly, we don't screen all that differently now, except in super high risk people than we did 30 years ago. I'd like to have better screening methods, but they're not that reliable yet.
Gotcha. If you could create your own screening method, do you have an idea of what you would do?
Yeah, if I had a screening method, the perfect screening method, it would probably be just something that you would you would just like spit on a there's a mouth swab or something where it was like non-invasive, but it can't just detect the cancer. It has to be really accurate, right? A screening tool has to be super accurate. It has to not miss any, and it can't pick up a whole bunch of stuff that isn't cancer and have a whole bunch of false positives. So the bar is set pretty high for screening tests. But yeah, a perfect one would be non-invasive and super accurate.
I love that idea. On a different note, Catherine M. was wondering, do you believe something like a post-grad program you went to is necessary for getting into research, or is it more important to be focused on it in medical school?
You can get into research a lot of different ways. I think, I think, so post-grad, do you mean like post-medical school? Getting into research post-med? You can do it. The short answer is yes, you can do it lots of different ways. If you want to do something like what my son is doing, an MD PhD, like he started doing research in high school, but he's a little weird, in a nice way, in a great way, but he's like super research focused. There are people like that, and he came in doing an MD PhD. He came from college. He applied to do a dual MD PhD program. You can be someone like me who says, I want to do research, but I don't really know what kind of research. And I'm just going to keep my, once I decide that I'm going to do an MD, I'm just going to keep, I did research in tuberculosis. I did research in AIDS. I did research in ischemia, meaning sort of loss of blood flow from trauma. So I did traumatic injury. I did research in lots of stuff. I ended up in breast cancer, but it was just because I liked answering questions. And then you have a lot of people who get it really interested in something while they're in medical school. And then maybe they take an extra year, or maybe they try and do some research while they're there. Or sometimes it's harder when they're in their training. Like a lot of training programs actually build in research time for people to kind of figure that out. It's a lot easier if you get some, training and show some interest in it earlier, because the further you get along, the less time you'll have to gain new skills, right? It's kind of hard to gain totally new skills once you're already a faculty member, because frankly, they hire you to do something, and it probably isn't research if you have no experience with research. So earlier is better, but there's lots of ways to get involved. I mean, I've got lots of my colleagues who kind of came to me and said, hey, how can I help? I'm sort of interested, but I don't have any training, and they help me. They participate with me, but they're not necessarily running things.
Gotcha. So there's not really one direct path.
No, there are lots of ways to get there.
Well, our next question, Fnu asked, they're doing an internship in a cancer research lab, and from their understanding, cancer can become resistant to many drugs and therapies that we use to treat it. How important is this factor in contributing to developing new treatments for cancer?
Very. The development of resistance is one of the biggest problems I suffer from. My patients, I get them on a drug. If I could get them on a drug that they're tolerating well, and they keep taking it, and the drug and their cancer never figures out how to resist it, then, particularly for patients I can't cure, we're done, right? They can do fine for a long time. And I do have patients where the first thing I given them, in fact, a patient I saw yesterday, the first drug I gave her, oh, it's got to be close to 10 years ago, is still the first drug she's on. Like I haven't used any of the other 10 drugs I've got that are like sitting in my back pocket because she hasn't needed them. Her cancer has never figured out how to grow on the, how to resist this. So it's crucial. Is it the only thing? No. I mean, it's not the only thing that's related to prognosis and how things, but it's super important.
For sure. Our next question comes from Helena. She was wondering, how did you find participants for your clinical trials?
Well, they come from our clinic. Sometimes they find us because they go looking for trials. I mean, I take care of patients. And it gets back to my earlier thing. My new job is to try and create trials and a system that lets the trials be more accessible, because I remember about the trials. I bring trials to my institution. And so if a patient's seeing me, they know that every time I have to make a decision about their care, I'm going to look and say, is there a good trial? Is there a thoughtful approach that's being tested that we might want to consider being in the trial of that? If you're in a community practice, they don't have access to that. The patient would have to come to me for me to take care of them and do that. And if they live 4 hours away, that's sometimes not really realistic. So, many times it's the physician who mentions it to the patient. Many times the patient says to me, hey, what about this trial? Should I think about it? And they've already looked it up. Just depends on the patient.
Gotcha. Our next question comes from Kirtika. What skills are important to working as a clinical trial coordinator or similar positions in that